Dr. Sada Danmusa, who we are very pleased to have with us at the resource team meeting because he is a very experienced public health physician who has a lot of expertise in strategic management. He has more than 20 years of health leadership and management experience in Nigeria and other African countries. And previously he was a Pathfinder and was also working at Palladium in recent years, where he was leading several maternal, newborn, and child health, family planning, and HIV programs. The last 5 years, he's been giving strategic support in Nigeria to national, state, and local governments because we have a 3-tiered health system, and he has been supporting the development and rollout of Cyanopress and DMPA in muscular. And so the work that he's done to develop several different costed implementation plans in different states has really contributed to elevating the FP agenda. And I'm sure you're going to enjoy hearing his most recent work. He's going to share about his experience leading a new, relatively young non-governmental organization, Nigerian non-governmental organization that he founded. How long? Maybe a year and a half or 2 ago?
Yeah, it was a year and a half.
Yeah, a year and a half ago. So please welcome Dr. Sada, as you already have. Getting to engage with him already, but now he's going to share his work.
Thank you very much, Laura.
Mm-hmm.
It sounded like it wasn't me when you
Can
I
That's when you know an introduction is really good.
You
don't recognize yourself.
Maybe we shall move to another person. But thank you very much, Laura, and let me also thank everyone for the opportunity to be able to come and speak about something that is very dear to me. I mean, facilitating government ownership. So even within the scale-up, I am really particular about facilitating government ownership. You know, Laura has made a lot of very good definitions about that, which, you know, they're quite ideal, but practically they are a little bit, still, fluid, how you be able to define them. So about 6 or so years ago, I think what she didn't say in the introduction, I was a consultant to National Primary Healthcare Development Agency. Now, whoever knows Nigeria knows National Primary Healthcare Development Agency. It is responsible for setting PHC development systems in the country. It's a national body, is supposed to be in charge of all primary healthcare services in the country. Yeah. And I was leading a team which is called Program Delivery Unit that is supporting the ED. The ED is the executive director. So you can see how important that is. But I think part of why I move away from just supporting scale-up, but really going to supporting government ownership in scale-up is what a remark I had. One day, one director in the agency came to me. So we had this session, a 3-day session to develop a strategy on how national primary healthcare will be able to translate programs all over the country. Its mandate is to take programs to scale, right? To develop the system to make sure that every program that comes at the national level or every intervention that is successful is got to the community. So we agreed that there is a need to have some guidelines, some strategy for it to be able to do that. So instead of having one program or one intervention lock up in one office, another, if we have some set of rules or some sort of strategies where they will be able to implement, it will make a lot of sense for the agency and for the country. And he agrees, so we have this very long conversations back and forth with consultants, and then we went for a 3-day strategy development workshop. Now, on the second day, we had a very stormy session talking about the role of national government, state government, local government, how do we get to the community? After we finished and we were having tea, a director who is supposed to be in charge of PSC development systems came to me and said that, doctor, everything you're saying in there is correct, it's good, that's what we need. But let me tell you something you don't know. You see, everyone you see here is here to get his share of the national cake. Now, when a Nigerian said his share of the national cake, you understand what it means. I mean, he's there for the money he will get for that. So all the discussion we're doing, the most important person there, who is the director of PSC development, had this feeling, had this understanding that nobody is serious. Now, I don't know whether he said that out of frustration with the system or out of connivance with it, but I think what is important to me was that there is something that I really didn't know. No tool, right, or framework can be able to translate any successful practice that we were trying to make within that meeting. If that man and his team do not commit to it and they don't even see that this is something worth doing. And if you consider this structure, you will see that the federal government is at the top of the pyramid, kind of. Now, the federal government with Federal Ministry of Health and its parastatals, the National Primary Health Care is one of the parastatals of the government. In fact, it's the biggest parastatal of Ministry of Health. It has the biggest budget. They form the policy and guidelines, but the states, which is the operational level of the healthcare system, are not mandated to take guidelines or policies from the federal because they are a separate level of government, right? So they can form their own policies. So what you have is federal government will have policies, state is supposed to operate them, but it's at their discretion to decide whether they want to do that or they will not. When you go down to local government, we have about 774 local government, and each of these local government has between 100 to 500,000 people. Each of these 774 local governments. Now, these are the lowest level of our governance system. Now, this is the lowest formal level, but they have the lowest budget. Their budget is controlled by the states. So they are there with the community, but they don't do much. The state controls the funding and the decisions. It's supposed to be a level of government on its own, but some constitutional issues have made it very difficult or impossible for them to have their money. Now the biggest issue is now the community. Quite recognizable, I've discussed about it. Quite recognizable system, but not recognized by the government. So you can see, no matter the tools and framework that you will apply here, it will require the government and high dose of commitment from the leaders to be able to take any practice to scale in a country like Nigeria. And that is my point. Mm-hmm. So, what I always see is that, development problems are usually deep-rooted. They are not open to quick fix. There will be emergencies, but in most cases, developmental problems are deep-rooted that require a long time to plan, right? That will require a consistent system in place for you to be able to bring in new things and expect it to be successful. So when people say that, we are scaling off in a system that is weak, and then when you look at it, nothing is being done to improve the system. Yeah. I just look at it as, this is interesting. I will give a small analogy that a director from the Federal Ministry of Health once gave me. He said that, take an example of a house. You are the head of the family, and then your neighbor close by or a bit far away just noticed that your children are not very active and concluded that they are not being fed very well, right? Maybe because you don't have enough resources, maybe you don't know how to identify what is the best way to spend your money. Somehow you are not feeding your children very well, and he decided to help you. And then he comes into your house and then said that, okay, I will do that, I will do that, I will do that. For example, he takes over the kitchen, how the cooking is done, to the extent of coming to the dining table and dishing out the dinner, right? And deciding who takes what and who gives what, giving out the money to the maid to go and buy. He will spend 2-3 weeks, he cannot be there forever. Perhaps within 2 months, your children will look better, but he's going to leave. And by the time he leaves, he will leave you with more problems than he has met, because he has, your leadership in the house of the head of the family has been almost eroded, right? Those who are serving, if you decide to take the serving role, those who are serving will now have to come back and learn how to be serving the actual portion and a lot of other things. And that is what we keep on seeing. You see technical assistants becoming more like replacement. People come into the ministry and take over the function of the ministry, and they'll be doing it. By the time they leave, that capacity is not there. And it keeps on saying, even this article when I was reading, they said that, yeah, capacity, when the donor is leaving, capacity must be replaced. And I was like, okay, so what was there before, right? You will see those resources drying out and leaving governments the worst for it. Just like you leave that house, that family man, with, perhaps you have increased the test, the living standard of the house, and now you're leaving, and the resources are not there. What happens? And the worst case scenario is when you leave, when you deplete that government commitment and leadership. By the time you do that, we are still trying to study what will happen if eventually the polio funding stops, right? If you go to Nigeria, I don't know, people that work in Nigeria, whenever national immunization days are happening, nothing happens in the hospitals, nothing happens at the local government. Because people are getting money, people have bought cars, people are living large, basically because of the money that is coming through polio. Now, we're about to eradicate polio. We're about to be certified. And believe me, there are some theories that polio should have ended in Nigeria, except for the fact that some people will still look for polio stool and take to the laboratory and say that polio has not ended. Basically because it's a source of income that is coming. But beyond that is, what are you seeing in the leadership? What are you creating in the leadership? I may be wrong, or we may be wrong that talk like that, but we haven't yet studied what effect polio is going to have in Nigeria when it leaves. The demand creation, how it is being provided, the system. So these are the key things that made us some years back to start thinking that, look, we need to create something to be able to support government, to improve how they deliver the services, how they engage with donors, how they get resources from the private sector, and these resources don't end up getting them the worst for it. So we want to create what we call a middle space. I will discuss the concept of middle space in a little while. But for now, it is an organization which I lead, which I incorporated with some colleagues. And we have a big mission of making the public service delivery more efficient. This is just what we put, ahead. How we do it, I will discuss that. And basically, this is what we put at at the top of our agenda. So what we try to do is to bring the private sector resources to make the needs in the public sector, but in a way that that head of the family is still in control, still has responsibility, has ownership, and be able to say at the end of the day that, okay, when you leave, this is how I'll continue doing these things without much disruption to what he is doing. So in terms of goal, we have this vision of creating, wherever we work or in the country, to have this system, these processes and leaders that are ready, right, to take on any practice that come, any intervention that come, and take it to the scale with little disruption to the system. If a program comes, they are ready, they have a system to just see how it will fit in and what is needed, what they need to do, and move it forward. And at the end of the day, when you leave, there is no disruption to the system. And I think that is the key word. We don't want to see disruption to the healthcare system in all of what we do. So to be able to do that, we brought out the concept of working from behind. Working from behind means that we could actually, at a point, disappear without causing issues to the government. So we don't take the center stage. We don't do anything on behalf of the government that the government should be doing. But we create that space for them to be able to do that. We have some key principles that we follow. First of all, we make sure that we co-create a change agenda. If there is an issue that we need to discuss, we create that change agenda, looking at, okay, what are the problems and what you need to do and what are the ways to be able to do it. And the government contributing significantly based on the capacity that they can bring in, thinking of how do we mobilize all the capacity within the system to be able to address that, and what do you need from outside to be able to do that. We also try to provide platform for consultation. So what we do was basically to ask the right questions. We don't lead the discussion, we don't guide it. We have them sit down, discuss, but we are asking the right questions, where you're going, and then be able to come up with the decision you make are your decisions. And they are more likely to be accountable if you make a decision from consultation, rather than coming us with capacity and telling you what you need to do or what you need to know. We, to support the process, we look for tools that are existing all over. We simplify them. We build their capacity to use them in such a way that it does not require very high-level technical skill for you to be able to do that. For most of the tools that you have, there's a basic understanding of what the tool does, and then we make sure that that tool is made in the way that no matter your level of education, you can be able to use that. Tools that are very complicated to use, we leave them out. Just look for those that we can be able to say, yes, basically, because by the time you have a complicated tool that is very useful, if it's not used, then it is not useful. So we make sure that, only useful tools, those that they can be able to use, we introduce. And then we try to create the right partnership for action. Basically, because in the development landscape of Nigeria, we are still at a level where we are not there yet to say that a donor comes and the government said, I don't want this, I want this, I don't want this, I don't want this. We are still at a level where donor funding still mostly control what happened. We see progress is going on. And our vision is something like Rwanda, where you will come, a donor will come, and the government will say that, oh, this is not what we want, this is our agenda. But we are still not there yet, basically because of so many factors. So what we do is to try to create the right partnership. The government decides, okay, look, this is what we want to do, this is our agenda, and this is how we are going to do it, who will support the process, and you reach out to him. Or if a donor or a civil society is around or is available, what do you have on your plate? Okay, look at what we are doing and see how we sit down and agree on how it will contribute to this process. Now, it's a little bit more difficult than that, because some implementing partners are already working in the field. So they already know what they are doing. Mm-hmm. So what we usually do is the government invites them to come to the platform and see what is being done, and then sit down, all of us, and co-create how they will be part of that process. So far we have done that with some organizations, but the key issue is, building capacity of the government to be able to do that on a continuous basis. So this is just an example of how we apply one of these models, or one of these methods I talk about. We are currently funded by the Bill and Melinda Gates Foundation to push the needle for family planning. So we are using a clustering mechanism where in the northwest part of Nigeria there are 7 states, the most populous and really the least in terms of family planning prevalence, and the southwest, which is the most educated region in the country and where you have the highest prevalence of use of contraceptives. So we have these 2 platforms separately. What we do is these 4 things that I discussed earlier. So we provide that space for them to be meeting regularly. Currently we do it quarterly, for them to come together, and we pick the data from those states. Their M&E officers do that. We give them a framework to look at that information, and then we come and sit down, and now they lead the process. They discuss what they want to do, they compare notes from the states. Very jovially they look at how the states are doing, and then go and use a bottleneck analysis tool, which we also simplified, and come up with what are the issues, what are the bottlenecks in each of the domains of coverage. I don't have time, I will have shown how we're doing that in terms of the simple tool. So they will look at those issues, they will now discuss, and they agree what they need to do. We feel that that kind of consultation is, making it much more accountable for all the leaders. Now, in addition to that, we also provide data analysis tools. So we do what we call data labs. So we have a day before the big leaders, the ES of agencies and the directors come. We have M&E officers come, sit down together, look at the data, and be able to, come up with what is the data saying for each of their states. And then the following day, the directors and the ES of agencies will come, and they will sit down and look at the data and look at what implication, and then have conversations between them. And after that, they will now sit together and agree on, this is what we want to do as a state, and then present those commitments to all the House. So when we come next quarter, we will review those commitments with the data and look at what they are doing. And we try to make it as, as non-judgmental as possible. Whatever you want to present, whatever you want to do, we only ask you the question and make sure that you understand what you are doing, and then we move forward. So we are looking at the processes, how they are imbibing that. One thing that we find very useful is bringing other partners, especially the civil society, within that discussion. So we try to, we make sure that the platform is formed and the leaders have understood that this is a government platform, and then they invited the civil society themselves to now come and be part of the discussions so that they can now be able to track what what they are doing at the state level. You know, and they are so open, and we feel that the civil societies are working with the government much more than we actually anticipated. So these are the key things, and I think one other thing is setting the agenda. For family planning, we just said that the bigger issue is women are not using contraceptives. So what we need to see women using contraceptives. So we set targets. Every state look at their trajectory and come up with what they want to achieve in a year. And say that we want to increase it by so percent, and this is the number. And then we collate for for all the zones, and we say as a zone, this is what you are going to be achieving. So this basically is really, we learn it from the Ouagadougou partnership, you know, setting the joint goal. And we find it very useful because when they come, they see that I said I'm going to contribute this, and this is what I'm contributing. I am bringing down the region as a whole, or I am helping the region move forward. So that healthy competition kind of thing is also helping a lot with the process. In the interest of time, I'll just move forward, but there's a lot to say about the way we do and the example. So these are just examples of some of the accomplishments we have been able to make, and I brought them out just to show how the governments are reacting to it. You know, when you look at the first bullet, we feel that the government is, the leaders are seeing the bigger picture. So there's a lot of discussions, and there are a lot of calls that we could have quoted, but the key issue is the leaders decided that, look, if you're doing this for family planning, expand it to include other MSCH interventions. And we think this is a process that we should all, everything we are leading should be, you know, managed this way, because it doesn't make sense to just concentrate on family planning and so you can only scale on family planning. We also note that resources are being mobilized more. States, about 3 states within a quarter, were able to use the data that they brought out within the data labs meeting to advocate for resources within the government and got resources released. For about 3 states, they have released, which they have never had for family planning, because of having that data and explaining that to one of them is Zamfara State, which has they didn't even have a budget before then, but by the time they went and, you know, provided the data, resources were carved out from other things and were given to them, and then they were asked to go ahead for the next cycle to develop a budget for family planning. And we saw improved stewardship for family planning programs, where states are going back and calling local governments and asking them, how are you tracking the data? How are you reporting it in the National Health Information Management System? And you know, I think for us and our partners that we work with, a big issue is we are streamlining the support from the states, for the states. So partners are approaching, and the state is saying that, okay, this is what we are doing. Look at where you are supporting this process, and then without us getting in between, they are sitting down with partners and making sure that this is what we said we are going to do, and this is what partners are supporting. So it's all moving toward the goal rather than you know, the different what they kept on doing. And we see one important thing, the increase in the use of National Health Information Management System, because this is a very big issue in Nigeria. Data is really a very big issue. What we noticed once we started, we realized that even though capacity is more in the southwest part of the country, when we came down and looked at the data from the DHIS tool, we realized that the northwest are uploading data more consistently than the southwest. So because we said we will not be using any survey data, will be using routine data, routine statistics. When we presented it to both tracks, the Southwest realized that they are, it's much, much lower. They said, no, this is not possible. We said, but this is what you have, this is what you have uploaded. And that's how they went back and brought the local governments and said that, okay, this is a national system, this is what you have to upload, and we'll make sure that it's being uploaded consistently. I mean, so this is part of what we think is the process for us. What is not important now as much, just increasing the number, more than having the process, imbibing that process, and making sure that the whole system is given that push to move forward. So these are just some voices from the field. I've just read the two on top. A director in the ES of Jigawa State said to me that, you see, the way you do not support us must change. If we are to meaningfully work and lead our agencies, everyone, every day one or another project will come and talk about one particular program when my role is for the whole PSC system. I think this is counterproductive, right? He said a lot of things, but really this is what captured my attention to what he said. And obviously he went ahead and made suggestions on MNCH, and they all agreed that it should be part of what we are supporting. And a director at another ministry who didn't want me to mention who he is, said that, look, there is a limit to how far I can push a plan to my boss, no matter how good it is. Some organizations have direct linkage to our leadership, and once they report you, you could be in trouble. This is not about the country, it is about donor funds. So you can see how that will reflect. He may not come out to say that. He will sit down and be smiling and be, saying the right things. And by the time we leave, you don't know what he is going to push for, what he is going to do. So just quickly, some of the key lessons we learned. Basically, I think we are moving forward, but definitely there are challenges. How you get this thing all across the country, or how you're able to sustain how this thing is done is still, we're still figuring that out. But some of the key lessons we have learned is that the basic question, that is supposed to be asked when you come with an intervention or a practice or a support, is it their capacity to be able to do that? But it's surprising that a lot of technical support does not ask that basic question. Just come with assumption that there is no capacity and this is the capacity you are going to build. When in reality, within that system, you could have some capacity that you could mobilize, or that you can strengthen, save resources, and not disrupt the system. What PEPFAR did in terms of getting health workers at facility, training them on HIV/AIDS, and obviously some other basic things in laboratory, equipping a laboratory far away from the main laboratory of the hospital, and paying or supporting additional payment for the health workers, could have been done, in a less disruptive way. Right? In my hometown, I have seen what is happening when PEPFAR left with the health workers, with the laboratories. Obviously, there is a lot of success in terms of managing the emergency, but there are things that we have to, take care of after everything is finished. And we feel this process of support is as important as what products the support produce for sustainability. And that's what we try to ensure we maintain. If you look at the analogy that director put, just having the children, more nourished, better nourished, and then leaving me for a lifetime to continue struggling is not as important as if you had taught me what to do. And we look at, we have some big guidance, right, that we provide the states. And basically, it is that there are key things that, as much as possible, you shouldn't give out. Direction setting, which is the leadership issue, and financing as much as possible, the government should do that. If finances are going to come to the government, then it should be that the government will determine or will agree this is where the finances should go. Right? So those are the key leadership things that definitely, if you take them off from the government, by the time you leave as a donor, the government is going to be the worst for it, because they will not be setting directions. And this is what we are seeing in many other programs, right? And very big programs that the government will have, and then once the funding ends, they will not know what direction to follow. They will just be reminiscing the successes that have been produced, but in 5 years' time, it will all be lost. That is one guidance. The other guidance we provided is that those services or those processes that would link to the beneficiary, as much as possible, the government should do that. If any donor is going to support that, then strengthen how that is done on a more sustainable basis. Because this is what we're seeing, the example I give in polio, for example. By the time you remove your support to those people that are creating demand for polio, those people that are going into houses and providing polio, the government cannot continue to support them. And then you are left with what happens to, to the system. Perhaps polio is maybe a little bit less because it's not hospital-based, but there are programs, there are donors that support service delivery at facilities, and by the time they withdraw, you will see the gap. And especially in family planning, we continue to see those happening. So we feel those are some of the key guidance. There are some coordination functions which donors can support significantly, consistently. How you strengthen the procurement system, how you strengthen how monitoring and evaluation is done. All of those things are a little bit more areas that funding, that donor support can take on. But of course, it's more like there's no hard and fast rule about it, but we're giving guidance to the government to be able to decide. So we also feel, support in certain areas is obviously counterproductive. Just as an example I provided now, if you are taking over provision of family planning at a facility as a funded project for 5 years, women are going to be using family planning. By the time a woman starts using it at 20, she still have about 25 to 30 years to use it. By the time you withdraw, what happens to her if the government did not take on those responsibilities? And we feel expectations need to be addressed early enough because they could drill capacity support. We have seen this happening severally at the federal level, where they come and they have this big expectation in terms of what the project is going to do, and then it is not addressed early, and then you will start talking of transition, you will start talking of building the government capacity to replace what is there. And I think what should have happened is expectations need to be set out clear. I'm very happy with commitments, global commitments that set expectations for countries, but in a lot of cases, those commitments also have their drawbacks because they are often brought about by advocating to the government and, to some extent pushing the government to say that you do this, we give this, you do this, we give this, and the government commits to, yes, we are going to do this. And then by the time you leave, by the time it is ending, you realize that what they said they are going to be committing is not what they are committing. So the expectation need to be set out in clear details. This is what is needed. How is it going to be done? Is it possible or is it not possible? You know, I know while I was at National Primary Healthcare Agency, I've discussed with the ED significantly in terms of Gavi. You know, they have a very good mechanism in terms of we withdraw this support, you increase your support, we withdraw this, you increase your support. But even at that, he sit down and said that, look, so how am I going to do that? From where am I going to get this money to put in here? Nothing said within the document how I'm going to do that, only that I should do that or I am going to do that. And we feel that is something that needs to be addressed by donors and implementing partners if government is going to take ownership of programs. So I think in conclusion, me and my colleagues, we see this as a big issue, as a big problem that we are trying to address. And it's certainly a very big issue. I was very lucky. I had an opportunity to select my team and bring them on board and make them partners, basically because I've worked at all the 3 levels of our healthcare system, and I met people and I have their views, and I know who shared the same view with me, and we came together and we formed this, and we are trying to continue to support that. We are not, you know, we are not, you know, what is the word I use? Perhaps we are not very sure that there won't be problems or there won't be some big difficult moments as we do this. You know, funding may end and donors may not see the relevance of doing that, and even states might not see the relevance of doing that. But we think it's an essential thing that must be done, that we have to come back to doing it, and we are ready to continue doing it, and we hope we will succeed. And I think the last thing is to request, you know, that on the expertise here and the experience here, if there are advices and suggestions and what you think we're not doing very well, please bring it. Thank you very much.
So would anybody like to take the bait that Dr. Sada has just